right. So as people come in, you guys feel free to let us know where you're coming from. We will have a replay available for this webinar. Um, but today we are talking about menopause and perimenopause, and we are just kind of looking at all of the things that are happening with people, women, once we hit that sweet spot of mid to late 30s and, into the 40s, and it's like a little hormonal free for all. And
Yes, it
so,
is.
and so I am Dr. Joanne Michelle Martin, pelvic floor PT. Just excited to be here with my amazing friend and co-host, Dr. Dion.
Hey everyone, I'm Dr. Deon Middlebrooks, as she just said, PT as well, and this should be a great conversation. So I'm excited about this topic because this is something that comes up all of the time, and not just with pelvic PTs. So I
hmm
can't wait till we jump into this information.
hmm So I kind of started off with a case, just kind of looking at, and I've got multiple screens, guys. So if you see me darting around, I promise it's not because it might be because it's Tuesday and it already feels like a Monday. Still, it's still feeling like that. But I wanted to start off with a little bit of a case and kind of just think about and also kind of open up the topic so we can think about the bigger why. Like oftentimes we hear menopause, and menopause really is just that phrase or that term for when menses end. So it's the end of that reproductive life cycle for women, which usually on average happens around age 51. But why is this such a big thing? And I think for a long time as a society, we've just dismissed a lot of stuff, not recognizing the true and the full impact of menopause. We have a lot of women have been dismissed. A lot of women have been told they are exaggerating. You're a little over the top. Well, that doesn't happen. All the things, you name it. I mean, women have stories for days. And I feel like, we as PTs, we see a lot. We tend to see people more than they see a provider, a physician, in any given year. And so there are a lot of things, a lot of concerns that might be brought up to us that might not have been brought up to the provider, might have been dismissed by a provider. They might just not have felt like it was relevant. And we're going to go into a lot of these, especially when it comes to a lot of the musculoskeletal concerns. And it's bigger than just saying, well, you just need to do some kegels, girl. Don't worry about it. Just do some kegels. But imagine you have a 45-year-old patient come in, and mid 40s is kind of a sweet spot. And they're coming in for shoulder pain. And they're talking about how their shoulder's been hurting, but they're also mentioning that they're really, really tired. They're complaining of all this fatigue. And you're treating her shoulder, but it's just not getting better. Like it's not improving. And you want to know what's going on with her, but you start to dig in a little bit more to maybe the fatigue. And she starts talking to you about her sleep. And then she starts talking to you about her overall mood and all these other things, which indirectly have nothing to do with the shoulder, right? Like you're sleeping, all this type of stuff. But Sarah is like the perfect, we're going to call her Sarah. She is like the perfect person for us to kind of consider to be in that perimenopause cascade, just because 90% of women, according to some research reports, indicate that musculoskeletal symptoms are common with perimenopause and menopause. So a lot of you guys, again, your clients are coming in, they're coming in for shoulder, back, hip, neck, knees, whatever. Um, and we're often not looking at some of the other concerns that we could probably be tapping into. Um, so Dr. Dion, anything to add to that?
I really like how you said sometimes our patients will just tell us more information compared to what they tell their physician. And a lot of times they're telling us more because they do feel comfortable, as you mentioned, but it's also because we ask the right questions. we have more time to spend with these people, so we're able to ask these women more specific questions and also dive into more as to, hey, let's talk about the weight gain that you mentioned versus,
Mhm.
okay, got it, you just gained weight. No, where is the weight gain? Are you noticing more so in the abdominal region? Has it been something that has drastically changed? Have you changed anything with your lifestyle? And they're like, no, I'm still eating the same thing, my sleep habits are still the same. Well, if everything is still the same, now we're able to help put those pieces together simply because we have the time and we are asking the correct questions.
Mhm.
And in addition to us asking these questions, like Dr. J just said, we start seeing this a lot of times in around 40s. Yes, it can start in the 30s as well. But with these women, with us asking these questions, we're the first ones to say, "Hey, how long have you been dealing with this?" Or let's talk about your period. Because that's a question we should be asking every single woman. And sometimes these women will tell you, oh, I haven't had my period in 3 months, or I thought I was in menopause, and after the 11th month, here we go, my period showed back up.
Mhm.
So we're the ones asking those questions so that we can at least better educate us. Say, got it. Here you are in the perimenopausal phase. It sounds as if you're getting ready to stop having your cycle soon. Here's what we can do to address your concerns and to better prepare your body.
Mhm. Also, they might tell you that when they have their period, it looks like a murder scene.
Yes, it does change significantly.
It
Six.
can change. It
Yes.
can change. And so you might hear all of the above, right? There's just a range. And so that those are some of the things that we have to be cognizant of. So ultimately, what's happening? We got some hormone changes. Everybody talks about estrogen. Um, and that's just primarily because we've got these estrogen receptors just about every which way in the body. So estradiol is the queen of the hormones. We've got receptors everywhere in bones and muscles, joints, all these types of things. It's really important for cardiac function in women, and cardiac conditions are the number one cause of death in women.
Yes.
So in older women. So again, estrogen is heavily linked to that entity. And so we think of all of the chaos that's happening, right? The follicles aren't really producing anything. We've got these estradiol changes, sometimes by 200 to 300%. So we're getting drops. We're not having, and estrogen regulates so much stuff in the body. It's inversely proportioned to like insulin and cortisol. And so again, we also have to think about what is life doing? Because if we're really, really stressed out and cortisol levels are high, that's automatically going to even suppress the estrogen a little bit more. And then we just think about that general timeline of what's going on, right? So again, those 30s into the 40s. So some of the things that we might see or we might hear people complain of is a lot more joint pain and stiffness.
Mhm.
As much as 68 to 79% of women going through perimenopause and menopause may complain of some sort of joint pain and or stiffness, muscle aches, and sarcopenia. So we're losing a lot of muscle mass. And because we're losing some of that muscle mass, this can bode poorly for like our bones or joint health, all these types of things. Fatigue and sleep disturbances. 75 to 85% of women will say that they are having issues with sleeping. Kudos to all of you who say I sleep like a baby. Not all babies sleep the same, so there's that. but but whatever that might mean for you. But but there are a lot of people dealing with fatigue and sleep disturbances. We have brain fog. It
Mhm.
is real. The brain fog. The I was doing this and you said something to me. Have you ever gotten mad at your spouse because you're focused, right? You got this thing on your brain, and then they disrupt that and they ask you for something, and then all of a sudden you don't remember what you were doing in the first place. So we've
Yeah.
got brain fog, word finding difficulty. You just can't mid sentence. What the heck is that thing called? So we've got word finding difficulty, low mood,
Mhm.
mood changes, mood swings, anxiety, and one of the things that we don't talk about enough or sometimes at all is the rage. We
Mhm.
be up in here getting mad for no reason. We're just angry, just angry, right? And I mean, and I say it kind of playfully, but it's the truth. Your wherewithal and your ability to just people. as we like to say, your ability to just deal is not there. Like that, we're done dealing. Like there is no, you don't have the capacity that you might have to tolerate people. We have frozen shoulder peaking, increased incidence of frozen shoulder, new onset of plantar fasciitis and tendinopathies.
Mhm.
Um, and at least 50% of women are going to report more than 10 of these symptoms or upwards of 10 of these symptoms at the same time or at some point in time. So, of all of these, as you kind of think through those, think of some of the things that you like. Not to mention arousal can be low because again,
Yes,
mood is
libido
low,
decreases.
dec- decreased libido. I was just having a conversation yesterday with a lady who was talking. She said, "I feel like sandpaper." She says,
Mhm.
"I could cut somebody. It is not comfortable." And I was wanting to, laugh a little bit at the analogy because I was like, oh boy. Because, she said it, and immediately I think of how abrasive sandpaper is. But there are a lot of women dealing with vaginal dryness. They're dealing with low libido. They're dealing with pain. They're dealing with increased UTIs. They're dealing with just skin changes, clitoral phimosis. The clitoris might just disappear. It just might. So we're dealing with all of those things. And it's really important for us as PTs to ask the questions because I guarantee in many cases, more often than not, nobody else has.
Yes.
So, Dr. Dion, jump into some of those for us.
And I just want to make sure that we emphasize, especially with this age range, a lot of times when women are complaining of these pains, this is the age range that they fall into. And also, just a fun highlight with the plantar fasciitis, there's another common time that plantar fasciitis runs rampant in women, and that's during pregnancy. And it's because of the same reason related to the estrogen and progesterone balance, because estrogen is not necessarily decreasing during pregnancy, but progesterone has increased so much to where even when you enter into perimenopause and menopause, you have a very similar type of effect where now you have the imbalance of the hormones. And estrogen might be the main driver, but it is not the only hormone that is changing and leading to the cascade of events. Testosterone is still one of them. It's still a main factor we have to consider. And just like Dr. J mentioned before, you have to also take into account the insulin cortisol balance and how the stress response that has on the body when trying to manage orthopedic injuries. And
Mhm.
we don't consider that. We don't consider the cascade of things that happen with the stress responses when it comes to managing orthopedic issues. We only think about metabolic issues. But guess what's happening? You're having a hormonal and endocrine based change causing metabolic issues that's also leading to musculoskeletal based conditions. So all of these things are related. If women have not had their A1C checked or monitored, they need to. They need to
Mhm.
be monitoring their blood pressure because all of those different things, just like we constantly drill into everyone now, you need to be asking about the menstrual health, but you also need to be asking about the overall basic lab work and that health as well. So you getting more information can help you better guide these women and also figure out what other providers you need to collaborate with. And I love that Dr. J mentioned, brain fog and anxiety and rage because we don't talk about the impact that it has. All we do, and she said it jokingly because that's how society has taught us to deal with it. Society
Mhm.
has taught us to pretty much say, "Hey, oh, she's just, I'm going through menopause. You know how that is." Well, one, why have we labeled in such a negative way? It has such a negative connotation to where we just assume that women going through this point in time that they're not going to be their best, that they're going to function at a lesser capacity when it doesn't have to be the case. There are different solutions and techniques that we can help collaborate with, we can help support and educate on so that we can get additional providers involved as well to not only improve their physical health, but their cognitive and mental function as well.
Mhm.
So, as the physical therapist, we play a role in the cognitive and mental. We play a role in the metabolic and the cardiovascular. We play a role in the endocrine. We just have to know how to better educate and advocate for people so that way these women can seek out the sources that they need because these things happen and these women will come to you with like she said with more than just one of these conditions. If you ask the right questions, you'll be saying check 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 and going down the list. And I guarantee no one else has put it together. Why? Because I see it all the time.
Mhm. Oh my gosh, it rampant, rampant.
There's
Like,
one other thing I know, because we're not going to probably go into a lot of detail, but there's one other thing I do want to add in when it comes to perimenopause and menopause. Even though we may be treating the women in this age group, the women that we see before this age group, help them prepare, because
mhm,
we actually start having a decrease in our estrogen in our early 30s. We peak out in our 20s. So we should be doing everything we can to physically and mentally prepare for the changes to come. So, yes, getting a good diet, but also resistance training, impact
mhm,
training, so that way you can have strong muscles and strong bones. Because as Dr. J mentioned, we're going to have those musculoskeletal changes, but if we load everything on the front end, the changes won't be significant or as significant on the back end.
mhm. Yeah, there is an amazing study. It was a Lift More trial by, I had it written down here, by Watson. It was done in 2020. What year was that? I want to say it was 2023. No, it
The
might have been
last
a
at
little bit earlier than that.
2024, I think
Yeah.
it.
And it was a trial about high intensity resistance and impact training and how it improved bone mineral density and physical function in postmenopausal women with osteopenia and osteoporosis. And so, and there, some other studies that came out as well, talking about different exercise intervention. One came out just this year on effects of different exercise intervention on bone health. But what a lot of the researchers have found is like we got a lot of women doing cardio. You are the exercise specialist, right? As a physio, as a PT, and everybody's out there just doing cardio. You see them in the gym and everybody's on the stairmaster. If we're going to do the stairmaster, do a little bit of resistance. If we're going to do the treadmill, start adding some intervals to the treadmill, start adding some resistance via inclines, start changing the speed. Don't just go in there and be on a leisurely stroll like a Sunday morning. Like we need to start adding some resistance. Then again, you want to meet people where they're at.
Mhm.
Strength training is not everybody's forte. Everybody does not know how to lift. Everybody has never lifted in their life, right? And so we want to make sure that we meet them where they're at. Some people might like to do Pilates. Okay, get on that reformer and let's start to work our way up, getting some resistance training in there. Ideally, I want to hand you a barbell, some dumbbells, or some kettlebells and be like, let's go. But that's not going to be for everybody. So we want to meet them where they at. Some movement is better than no movement. And then we want to progress them as we are able to, even if we can get them doing some good body weight training. But it's really important for them to start doing some sort of lifting and strength training because this is going to positively impact the bones. The bone density is related to that force that's being placed on them. So when they're not doing anything, they're just being sedentary. That's going to impact bone health. But also, we just said estrogen impacts the muscles because we got receptors in the muscles. We're going to lose muscle mass as we age. We don't have the muscles. The muscles are attached to the bone. We need the muscles. So we also want to look at their nutrition. Are they eating enough protein? And I know I feel like protein has been getting beat a lot lately. Everybody's like, eat protein, eat protein. But there's a reason for that, especially as we age. Are they eating enough protein to help with sustaining muscle quality and muscle health? It's going to be really important. So these are some of the things that we want to make sure that we're telling them. That there again, research says bone loss accelerates 2 to 5% per year in the first 5 to 7 years post menopause, and 1 in 2 women over the age of 50 will have an osteo would or could have an osteoporotic fracture. So if we are the exercise specialists, we need to be talking to them about this because they're not hearing it from anybody else.
And I love that you brought up nutrition, because what is one thing that women do when they start having these body changes because of menopausal symptoms? They go on diets. And they
Mhm.
go on diets where they're not properly educated. And if you have someone, as Dr. J mentioned, who is doing a very hard cardio based exercise routine and they're on a diet and they're restricting carbs, their bones will be impacted.
Hmm.
This is a conversation I have to have with a lot of the runners. Hey, especially with certain sports that women expect to try to maintain a certain body type, they start cutting back on certain calories, and there's certain calories I need you to have so that way you can sustain. So
Hmm.
yes, protein is important. Protein is very important. A lot of, especially in the American diet, a lot of people don't get enough. But if you're on the exercise side, you actually might get too much because they drive so much protein in diets now with that. But one thing that I've seen is that people cut out carbs. They cut out
Hmm.
all carbs. And yes, there's good thing is some that are not as healthy as others, but your body still needs carbs to function. It's your main energy source, and your bones are going to need that for health as well, especially if you're doing a lot of cardio-based endurance training.
And your
That's going to be
brain.
key. Say it again.
And your brain. Your brain is going
Oh
to need
yes, yes it
carbs.
does. Yes it
Your
does. Your
brain is
brain,
going to need,
all that energy,
you're going to need
all
some
of it.
carbs to function. If not, that brain fog, let me tell you, it's going to be
It
bad,
gets
bad.
worse.
Eat the
It gets
chocolate, okay? Eat the chocolate. So I say that very honestly. I will eat the chocolate.
me
Uh,
too.
but when we think about other symptoms, mental health, this is a big one. And I think I'm grateful that mental health has gotten a lot more airtime in the last several years. But there's a four-time increase of new onset depression and perimenopause, right? So we know that there's a huge, and for many reasons. We've got the impact of estrogen, we've got the impact of pain. And when we look at pain science and we think about how pain and potentially chronic pain can impact overall mood, that is a huge one. We also have body changes, right? Because again, now that we're having these estrogenic changes, there's probably likely a little bit more of a struggle with maintaining what one might perceive to be their ideal weight. And so now we might be dealing with a little bit of insulin resistance. And so now that can also factor into, I don't like how I look. My clothes can't fit. I don't, and so we're in that phase where there's a lot going on. And so we may be having a lot of depression linked to that. There's also the anxiety and rage episodes. Anxiety is real. And I've worked with more women who have had these late adult onset diagnoses of anxiety. They can't keep things together. They're having brain fog. It's causing them to panic, all of these types of things. And again, as the musculoskeletal experts, I will say exercise is one of your best non-prescription, non-drug based recommendations that you can make. Very good effects on um, serotonin, on dopamine, like a lot of great things come out of that. So, I mean, just encouraging people to move, encouraging them to try things, try new things, find something that you like, go dance. That might be helpful. And then
Go
the other,
outside.
get outside.
To go outside.
Yeah, just go sip some tea on the
Yes.
deck.
Yes, with the sunlight. So exercise and make it
Hmm.
outside. Nature. We have a lot of research that supports just being out in green space. It's
Hmm.
actually like they call them now green space studies. But
Hmm.
even outside of the green space, the sunlight, the vitamin D that your body's getting, not just good for your bones. Vitamin D is wonderful for your mood. So
Hmm.
just wanted to make sure y'all exercise outside as well.
Outside, just be out there. And then sleep, because if we can't get sleep, we can't function. And Lord only knows how we function in our 20s when we would sleep 2, 3 hours and wake up with all the energy of the world. I mean, I don't understand it. All I know is that now that doesn't work very well.
Nope.
So we need sleep, right? We need to make sure they're getting sleep. And so oftentimes that's not a question that many physios are asking when people are coming in. If somebody's coming to you and they're coming in with pain, they're coming in with fatigue, one of the questions you need to be asking them about is their sleep hygiene, because there's also a lot of evidence that supports um, good sleep hygiene is linked to reducing chronic pain levels and and consequently, if we're not sleeping well, that can perpetuate pain. So we really need to make sure that they're sleeping a lot, and or they're sleeping well, I should say.
And when it comes to sleep, we don't always think about how important sleep is for other things. Sleep is a time where your body has a chance to repair and recover. And if you're not getting quality sleep, so it's not just about the number of hours that you're getting, because you can have 7 hours of sleep and it'd be terrible. But
Hmm.
we also want you to have quality sleep. So they say that between the hours of 10 to 2 is when we should get our best sleep. So that means that you may need to go to bed before 10.
Hmm.
Not after. That means, and also maybe like, especially if your day is starting at 5, you probably need to move your bedtime up. Okay. So that way you can actually get into the true deep sleep. That way your body, your brain, all those different systems have a chance to start the recovery and restoration process. If you're not allowing that, your chances of becoming injured when it comes to the musculoskeletal side increases significantly. Your chances for gaining more weight increases significantly because now the cortisol levels are all out of whack and out of balance. Your
Hmm.
stress level is going to go up because why? Well, I just mentioned cortisol, so that's one reason. But now also the brain fog is worse because you can't function because you're tired, and which is leading to you being irritated. So you're causing even more issues simply because of poor sleep habits and hygiene. So working on trying to improve sleep. And I know one common disruptor of sleep during the perimenopausal, menopausal phases are, the night sweats and the hot flash and those things. And if you don't get anything else from this, you will know the importance of exercise because you can actually decrease those occurrences through exercise and resistance-based training. And you've already heard us say, both Dr. J and I, we prefer weights. We get it. However, if that's not your jam, then let's do some body squats. Let's do, some planks, but getting the body to challenge itself so that way you can get the heart rate up, challenging the heart, that cardiovascular system, because that is linked to your hot flashes. There is a direct relationship. So if you don't get anything else, you'll at least understand the importance of exercise from this talk, because
Hmm.
that's going to impact how well you sleep. That's going to impact some of those vasomotor symptoms with the night sweats and also with the hot flashes, even as you're sleeping as well.
Hmm. If you live in a home that has AC, turn your AC down. Keep your room around 68 degrees to go to sleep. There's some research that shows if we keep cooler temperatures, that can help with getting a better night's sleep. So making sure that we keep the room a little bit cooler, making sure that we're turning off technology, your phone, your TV, at least a couple of hours before you go to bed. Do
Yes.
not go to bed with your phone, okay? There's I was listening to a researcher on pain science who said the bed is for sex and sleep. So
Yes.
that's all you need to be doing in your room. Turn off the TV, turn off the phone. You can have some music playing. If you have a smart device, Alexa, Echo, whatever, you can have some music that plays like low volume just so you have some ambient noise or whatnot, if that helps. But you really need to just kind of focus on sleeping at that time. Um, and then one of my favorite topics, sexy time. Sexy time, y'all. It's real. It's real. There are changes that happen. Okay. And
And not
so,
just dryness. It's more than just dryness.
first of all, I would encourage you to get a handheld mirror and take a
Yes.
look.
Yes.
Oftentimes, we don't know there is an issue and we don't know what normal is until there's an issue. And then it's like, well, what's happening? Well, I just know that I have pain. Okay. Has anything changed? I don't know because you've never looked. Looking at your vulva is no different than looking at your arm, looking at your face, looking at your hands. You look and you assess other body parts to make sure that they're okay, they're healthy, there's nothing going on. You need to be doing the same thing with the vulva. That's one.
Yes.
Two, the same way that you moisturize your body, I want you to moisturize your vulva. Okay. This could be as simple as you get a little bit of coconut oil and you just go ahead and on the vulva. This is externally, right? So we're on the vulva, we're on the external surface, making sure that we are doing some sort of moisturization. Now, here are the benefits to that. The same way that you lotion your skin, it adds moisture, it helps maintaining the integrity of the skin, it helps bring blood flow, those types of things. All the same benefits for your vulva, all the same benefits. And so we want to continue to do that because as the estrogen starts to change in the body, it impacts the vulva. It impacts the tissues. People notice their tissues are drier. People might notice redness. They may notice itchiness. They may notice a little bit what feels like scaliness. Oftentimes that might have to be differentiated by a vulvar dermatologist from other skin conditions of the vulva, but you may start to notice some of that. And a lot of the time it's due to those estrogen changes. Like I mentioned, the clitoris might disappear. That is
Yes.
the number one sensory organ when it comes to arousal and sexy time. So listen, make sure you can keep it, okay? Make sure it's there. Make sure that the hood of the clitoris is mobile and it can move. We want to make sure that it is present. We want to make sure that we're assessing for sensation and those types of things. And then one of the things that typically tends to get a lot of people is I oftentimes will recommend start using some lubrication. Do not let the dryness get the better of you. Okay. As your body changes, sometimes you just need a little bit of help, and that's okay. There are plenty of different lubes out there: oil based, water based, aloe based, silicone based, CBD. If you want to keep it, funky fresh, like whatever. You've got so many options out there. Find a lubricant that you like, that doesn't irritate you, that you can utilize to help with assisting with pleasure with intimacy and intercourse. There's no reason why you shouldn't use them. There's no bad connection to using them. It's only positive. So go ahead and make sure that you're using some type of lubricant.
And you don't have to wait for things to start to change to start using a lubricant. So you can use lubrication way before then. And I tend
Hmm.
to encourage it because it can decrease friction. Even if you're not having issues, it can just make the experience more enjoyable. It can make, sometimes people are like, oh, initially I have just a little bit of sensation where it feels strange. Adding lubrication can decrease any type of friction with that. So even beforehand, but definitely if you have not been using lubrication, please start. That is something that's very simple, very, very easy that you can do to try to help, like she said, with the health of the tissues. And you'll have, like, it was mentioned that the clitoral hood itself, that you start noticing changes not retracting. The clitoris starts to disappear. The labia also starts to thin. And then
Hmm.
people tell me it's not as plump as what it used to be. What you can do to try to help maintain that blood flow. And she mentioned, the tactile stimulation of rubbing and using lubrication. And I'm going to go there. We also have the tactile stimulation of vibration. So vibration does not just have to be, pleasure based. It can be therapeutic. There are therapeutic
Hmm.
reasons why we can utilize vibration for strengthening the pelvic floor muscles, since that's a hot topic with people all like, oh, menopause, pelvic PT. There's so much more as you've already heard. But yes, vibration can be used to strengthen the pelvic floor muscles, all muscles actually, depending on how you use it. And vibration can be used to also help with improving the health of the tissue by allowing for improved blood flow to this region. So
Hmm.
there are times with my ladies where it's like, okay, let's figure out what the issue is. Part of the issue is arousal. So sometimes it's, the blood flow portion of we're not getting the blood flow to the area to allow for arousal. Let's try implementing, tactile touch. And tactile touch stimulation can include that vibration based sense as well. So just being mindful that, because I know depending on your own beliefs, depending on the environment that you may have grown up in or may currently be in, there may be some preconceived thoughts about vibration. It does not have to be just for sexual base. So if that is a barrier, you're hearing me say it does not have to be for sexual base. It also can have therapeutic purposes that can benefit other things.
Hmm. Absolutely. Go get you a toy. Toys save lives. I'm gonna put that on a shirt. Toys save lives. And I love to joke, y'all. I really do. But seriously, like Dr. Dion said, I encourage the use of vibration individually. I encourage the use of vibratory toys as a couple, not necessarily for the intent of intercourse.
Yes.
Penetration doesn't have to be on the table, but for the main purpose and intent of pleasure based play, and working individually and working with your partner to help with just reacclimating to that. Because again, sometimes, just the overwhelm of the changes happening in the body, it can be a lot, right? And people might go weeks, months, whatever, without having any sort of intimate touch. And it's a really good way to just gradually reintegrate that back into your lives. So, when we're thinking about it, that is one of the things that should be kind of high on the list if sexual intimacy is a priority for you. Um, In terms of how we address these, we've talked about a lot of the stuff already. Some of the things, that we can do. One, we can encourage activity,
Hmm.
encourage strengthening. We should also be screening every woman. I mean, and it can be as simple as they come in and you ask them, have you noticed, questions about the period? Have you noticed your periods becoming irregular, your flow changing, your period stopping, whatever have you? Just ask them about their periods. You can ask them, have you been bothered by hot flashes or night sweats or any disruption to your sleep? And you can ask them, have you experienced any joint pains, mood changes, increased anxiety, brain fog, vaginal dryness, or energy changes, right? Three simple things that you can ask them. The reason for this is you want to kind of gauge where they're at. They might say no to all of them, but if they say yes to any of them, then we know we might start to need, make some referrals, right? We might start to give some education, but part of that is also being able to make the necessary referrals and collaborate with providers in your area, the gynecologists, the primary care doctors, and so on, the urogynecologists if they're having recurrent UTIs and different things like that, so that they can get the help that they need. I also will encourage all of you as PTs to start implementing some sort of mental health screen. The patient health questionnaire is a 9-question questionnaire. It is very good and it is a validated tool for assessing depression. You do not have to treat the depression. But it is important that you, when you're listening to your patients, because sometimes they might have been dismissed by other providers. And so now you have a validated tool that you can utilize, send a letter to the doctor, send a note to the doctor to say, hey, here's what we've got in our findings. This person is presenting with some findings consistent with depression. You can refer them to a mental health therapist, whatever have you. But it gives you an opportunity to start having some more dialogue with their providers and really making sure that they're getting the help that they need.
No, I completely agree. And we said in the very beginning, we're the ones who we ask the correct questions. We have the time to ask these questions. When you're asking the questions, one thing I want to make sure is that don't just write down the answer and move on. Be willing to dive a little bit deeper because sometimes people will give you a robotic answer and then they expect for you to move on because that's what most providers will do. Also, if someone does mention something where you're like, okay, this can be something, a potential concern, especially when it comes to mental health, something of that nature, be willing to know that there is a limit, as Dr. J just mentioned, as to how much you can do. We, even if we have a mental health background or trauma informed, that is not our role as their physical therapist, as their
Mhm.
physio. So don't try to take that burden upon yourself, but that's where the collaborative care is key. Just as you would not try to take treating a cardiovascular issue upon yourself. You know your role in that, you know what you can do when it comes to exercise-based prescription, and the same exercise-based prescription can be utilized with mental health components as well. We just have to make sure that we are properly implementing them and that we're properly referring. When it comes to these patients, also recognize that there is a good chance that they've been experiencing these symptoms for longer than what they're willing to admit, and they may have frustration because
Mhm.
people don't tend to believe women. And it's unfortunate, but we a lot of times gaslighting is still an unfortunate consequence of women receiving medical care. So I ask that you not become that provider who just kind of brushes it off and says, "Oh, you're 50. That's why your back is hurting. Oh, yeah, you're 50. That's why your shoulder's hurting." Don't become that provider. Help her find solutions so that way she can get back to thriving in life. That is our whole purpose, is to help restore function. And if we're ignoring their complaints, we're not able to best and effectively do that.
Yeah, absolutely. Validate, 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 and educate. Just make sure that you allow them to acknowledge that you hear them, that you are listening to them, and then make the necessary recommendations. I think one of the last things I want to mention is definitely lifestyle again. A lot of the times we can make simple changes that can do wonders, right? So again, we're PTs. We do not have prescriptive power. We can partner with other providers if we know that they're experiencing these symptoms, and we can get so they can get some topical estrogen. or they can get some other type of hormone replacement therapy. Maybe it's progesterone that they need. Some people tend to be, especially with autoimmune diseases, may have a little bit more sensitivity to estrogen supplementation. So making sure that we are aware and we can refer to the necessary provider. Activity, increasing their activity, making the lifestyle recommendations, their sleep, turn the temperature down in the room, like simple little things, their diet, managing their stress. That might be work, that might be home, that might be life. Can we give them tangible tools just so that they can manage that? Because if they can't manage that, they're not doing your home exercise program. So if you want them to do your home exercise program, if that's important to you, we've got to make sure that they can navigate the things to put them in a better position to be able to follow through with their PT plan of cares. And so, again, just kind of thinking through what people are going through, we've got to be able to meet people where they're at. And we've got to be able to appreciate that when we're thinking about perimenopause and menopause. This is a very complex time, and there's a huge variation of symptoms. I mean, and we didn't even bring up the beautiful, chaos that is being a postpartum mom in perimenopause.
Yes.
So it's fun times over here, fun times. So when you are postpartum, because we have a lot of women who are delaying, family planning for one reason or another, and may now be having kids, mid 30s, early 40s, and right on the throes of these other hormone changes, that is perimenopause. And so there's a lot more happening, a lot more they have to juggle and navigate. And so we need to kind of meet these people where they're at and recognize it doesn't mean that they cannot handle what life is throwing at them, but they might just need better ways of doing so. So don't just assume they can't. Don't just assume, oh, well, she's in pain, like Dr. Dion said, it's because you're 45. You've got a little bit of weight. Well, why does she have the weight? She just had a baby. So how do we help her navigate, maybe some of the changes in her body? You know, what type of pregnancy did she have? Was she sedentary? Was she high risk? Like we're trying to come back in to normalcy in a sense. So how do we help her navigate that?
And we're the ones who are teaching this to patients so they can take it back to their other providers.
Hmm.
They oftentimes don't know how to advocate because I've had a lot of postpartum women where they're expressing things and people are telling them, oh, well, it's because you're postpartum. But when you start asking more questions and you're realizing what box they're checking, yes, they are postpartum. But looking at your age and some of the other symptoms that you're mentioning, this sounds a lot like perimenopause. In addition to you, not only now do you have brain fog because of perimenopause, but you have mom brain. Those two things combined can be a traumatic experience for someone who's used to being a high achiever and someone who's used to constantly remembering and being kind of the life source for the family. So you have to take those things into consideration as teaching, hey, this is what I see is going on. I want you to try these tools, but also let's talk to your other provider so we can get you support that you need. And in some cases with postpartum, there are times where providers will also recommend hormonal replacement therapy. And I'm going to say, because I know Dr. J mentioned hormone replacement therapy briefly earlier. For most women, I didn't say all, for most women, hormone replacement therapy is a safe option. There are different reasons to use it. There are different ways to receive it. Okay. So it's not a one size fits all. So sometimes you are playing around not just with the dosage, but also the method of delivery. And you may be playing around with the time and the phase as far as where that woman is, if she's postpartum versus if her kids are now teenagers. So that also may impact. And you also have to consider the lifestyle because I had one lady who comes to mind readily where they gave her the patch for her estrogen. Well, every time she would go run, she would sweat and it would come off. That's not effective for her. That's not an effective means for her delivering the medication. So we had to look at other options for her. So I'm going to say it again. For most women, hormone replacement therapy is a safe option. I also will add this caveat in there as well. It is not an option for all women. Okay. So even though it may be a safe option, women still have the autonomy to choose. So some women may say yes, some women may say no. They should not feel pressure either way. Our job is to present, the knowledge, present the education, the reasoning, the risk, and the benefits. That is the true meaning of informed consent. I'm not going to go down that rabbit hole, but that is a true meaning because you want to make sure people understand that whatever you do, there are benefits, but there are also some risks. So that way they can make the best informed decisions with their providers. So our job with HRT is to come alongside, educate so they can make an informed decision.
Mhm. Absolutely, absolutely. So to wrap up, guys, I hope you hear us clearly that this is not, we think about, we could spend hours talking about perimenopause and menopause and the nuances that exist when it comes to this topic. But one, understand that there is a lot of variation in how people are going to present. Understand that our roles as PTs, we are still the musculoskeletal experts, and estrogen plays a role in how our body is able to function. And so our musculoskeletal system is going to be impacted as a result of these estrogenic changes. Understand that there are a lot of factors that impact how one can function. And so we need to be mindful of those things. Understand that mental health is an important component to the overall well being of your patient. We have to screen for it. We have to. And finally, know when to refer. Know when to refer. Start getting familiar with all the providers in your area, with all the OBs, the gynecologists, the urogyns, the nurse practitioners that deal with menopause, perimenopause, all these people. Get familiar because it's going to be very important for your patients to have resources that they can go to for any of these issues. All right, guys, I've got a few of you on. I've got a few minutes. Any questions from anyone in the chat? Let me just make sure. Any questions, you should be able to go ahead and put questions in the chat.
And in the chat, just in case you all didn't catch it when Dr. J mentioned the questionnaire that you can use for mental health, I'm going to put the name of it in the chat for you all, so that way you can have that and refer to it because it's a quick and easy tool that you can give your patients.
All right, we don't see any questions coming in. Dr. Dan has put that in there, the PHQ-9 questionnaire. You can Google it. Just Google PHQ-9 questionnaire PDF, and it should pop right up, and you can see that. We will have this available for replay. Feel free to share with other providers in your area. Feel free to contact us. You can contact me, info@thepelvicperspective.com. Dr. Dion.
I'm info at Rain PT, so that's REIGN PT.com, or you can find me on Instagram, and that's rainpt.wellness. That's probably the easiest place to find me.
Mhm. Yep, the pelvic perspective on Instagram. But find us if you have any questions pertaining to this topic. Please feel free to reach out to us. Feel free to contact us with regards to that. We're happy to help. But just know that as PTs, again, we're seeing these people already. Why not? Let's give them the best care possible.
Yes.
All right, guys, take care.
Thank you all. Have a good evening. Have a good day, depending on where you are.